the name of it. In the House is Dr. John Mitchell, President MSMA, the Mississippi State Medical Association Board of Trustees. Good morning, sir. How are you?
Good morning.
It is a pleasure having you. I thank you. Doesn't look good for Medicaid expansion right now as far as one of the big issues. I think the Senate met the demise of the initiative process yesterday, and nothing is dead, but we're getting to that period. So your thoughts on this one as far as a physician and looking at this, what's your plea to the legislature?
Well, my plea both to the legislature and to the general public is to talk to their legislatures and convince them that this is the proper thing to do, both financially and healthcare-wise. My view is, in the sense that I'm a small business owner as well as a physician. I've done a lot in my life. And I see the benefit from this expansion for some of my actual employees. And they're working, but it's the working class poor that we really need to address this access to health care expansion. And I would plead with our legislative body and et cetera to explore all sources, all possibles, before laying this on the table, that we need to expand access to care both for humanitarian reasons and for financial reasons for Mississippi. It could be a positive. Yeah. When you look at business, everybody wants to dwell on the cost. Business, everything in business costs, but you make revenue off of that cost. So let's look at the Medicaid expansion side of revenue generation for the state of Mississippi, as well as what it's going to cost us. And right now we're in a great position because the feds, will pay 90% of it. And somebody asked how long. I don't know that. But we also have access to a 5% bump in the APRA funds and et cetera for 2 years. So we can, by studies, show that probably for 6 years at minimum, it won't cost Mississippi a dime.
I guess if you use this as an analogy, Dr. Mitchell, let's just say in your small business, if you're finding it most difficult to get people to go to work, every single day you open up and you find out somebody's not showing up, you don't have enough people, you've got to curtail services, and all of a sudden you pass a government program in the state of Mississippi that's going to exacerbate that to where the next Monday after it's passed, you may have the problem increase by 20, 30%. And that's one of the things that I hear from legislators that are on the fence on this thing, because unless we get a work requirement in there, you're going to have, in some cases, not only that, you're going to have, we're number one already in the people who can work, not working.
Well, I guess there's a proposal that those people wouldn't show back up, but I contend that the probability is if you're working and you have the access to the health care, you're not going to quit working because you would take a step back both financially. I mean, it's and there's a study that came out this morning that was passed on to me, but I hadn't had a chance to read it yet. But it showed that probably when you take into consideration of the work requirements and et cetera, there may be 30 or 40,000 people in Mississippi that would not be working. Most would either have work employed positions or exemptions to child care or other things, et cetera. But there would only be, with all the rigor of work requirements, the number of people that would address is fairly minimal.
Well, in a situation where you need more workers, especially now with our economic outlook is getting better and better with the new jobs that we're about ready to kick off as these major projects get underway. But on the flip side of that one is this, that I think the Senate bill, and I'm not sure what the latest, because it's going through a lot of changes. One of them was to basically say that if you are working, then you would be, it would be applicable to your being qualified for this program. In other words, you have to be working now. So that's kind of roundabout on the work requirement. So if you are working, you would be part of the Medicaid expansion. But if you're not working, then you couldn't partake in it.
unless there was other exemptions. And I
Well,
agree.
sure, if there are physical exemptions or
And
mental.
there's language in there that you can't just drop your insurance and move to this without waiting a period of time. There's some safeguards in there, but our plea is, and I've worked in, as you can tell by the gray hair, I've been in medicine for a long time. And we've had free clinics in North Mississippi where I practiced in Tupelo for the working class. They all had to have a job in order to qualify for even that free care. They didn't give up their jobs because of that free care. And so I think the great debate, in a sense, as you said, would my employees quit coming in because they got Medicaid and health care? I don't think so. I think they would use that as an advantage to continue to work and just have, health care access.
Well, that other little caveat that you mentioned, and again, my guest is Dr. John Mitchell, who's president of the Mississippi State Medical Association. The other little caveat that you mentioned was that if you had a private plan, you could not get off of it. The house plan, from my understanding, would actually kick off more than about 140,000 people off their private health insurance plans, and it would force them onto Medicaid. If that is true, then you've probably got a little tsunami or a wave that's going to infect the entire insurance market for people who are over that qualification level.
Yeah, you're talking about marketplace, usually
Yes,
not
marketplace
just private
consequences.
insurance. And marketplace insurances have not got the best coverage in the primary care sector. So we've struggled with some of those in the sense they're great for, I think, catastrophic or major problems, but in the primary care arena, which we need individuals into the healthcare early on to address some of the problems. That particular insurance has not been as productive in that. So would some move from marketplace to that? But I think there's also some caveats in that bill that that either limit that or, I don't say totally prevent it, but I don't think you'd see the tsunami effect. You may see some effect.
Have you had conversations with the House and or Senate?
Yes, we've met with the leadership of both, and as you know, the House passed its bill, 99-20, which they got to work very early. I think it's 1725. And as you said, in the Senate, they didn't actually take up their bill. It died down. Our only vehicle is the House bill, which we hope that they will address and come to conference and come to some agreement, because we need to pursue, like I said, all avenues. MEC said it best, and we need to explore. Because this is an economic issue too for the business world, not just the healthcare world.
The Senate acclamation of this is going to have to be as strong as the House, because the governor has already said that he's going to veto it. Your thoughts on that?
I don't disagree. I think that he's drawn the line in the sand, et cetera, and I think that it would have to be a veto-proof majority in the sense of the Senate joining on board. I mean, it is what it is. I mean, we all live in the political world, and sometimes it's all about politics, red and blue.
It is all about politics.
More so than it is about the people.
Let me ask you this final question here. When you were a young man and you first started, and as a doctor, did you do house calls?
I've started, oddly enough, as a pharmacist. I practiced pharmacy for 8 years. So I had a lot of groundwork in the community and whatnot. When I first went into the little town of Pontotoc, I wouldn't say that I made a lot of house calls, but a lot of people came to my house for calls.
How about that? Just come on by the doc's house and you take care of them there.
Right.
Well, it's good to have you in, sir.
Done many procedures on the back porch.
I won't even go into that. I mean, none of them were colonoscopies, I hope.
No, none of them were that flavor.
That invasive on the back porch.
But
I guess that would be a proper place for it, though.
One other comment that I think is very important.
Sure.
I am the director of the Office of Physician Workforce, which in my day job. So we've built residency training programs all over the state of Mississippi, including the heart of the Mississippi Delta. um, these individuals, if we want them to practice in the Delta or any of the underserved or rural areas, they got to have a payment source. And I think this would go a long way in the sense of giving them viability to go back to those rural areas to practice. And so,
Good points.
I
Good
have
points.
I have a dual, I guess, emphasis on why I think this would be good for the people, for the public, for the economy. I think that we leaving too much money on the table that we can actually use to leverage into more federal dollars. And plus, I think it would be a recruitment tool for the